totally perfect. That's what she's most excited about.
Yeah,
So
that's awesome. Yeah.
so, it was like, yeah. Wonderful.
All right,
Okay.
everyone. Thank you so much for being here today and for bearing with our technical issues. I apologize for the late start. My name is Meghan Moran. I'm the assistant department head of our customer services department here at the Oakland Library. And I regularly work with Jyothsna in community outreach at Advocate Aurora Health. And she is kind of one of the people that has helped bring Dr. Palla and Dr. Mital here with us today. So I'm going to give you just a brief introduction to both of them. And thank you so much for being here with us today. So Dr. Palla is going to be our first speaker. She specializes in endocrinology and diabetes metabolism. Her clinical interests are continuous glucose monitoring system, hyper and hypothyroidism, insulin pumps, low testosterone, osteoporosis, polycystic ovary syndrome, pituitary disorders, thyroid cancer, thyroid disease, thyroid nodules, and weight management. Dr. Palla attended medical school at Advocate. Thank you. I'm sorry I didn't get a chance to ask you how to pronounce that properly. Thank you. Medical college. She completed her residency in internal medicine at John H. Stroger Hospital of Cook County. Dr. Palla completed a fellowship in endocrinology at Rush University Medical Center and a fellowship in geriatrics at Loyola University Hines VA Hospital. Her office is located at 3330 West 177th Street, Suite 1A in Hazelcrest. And she is affiliated with Advocate South Suburban Hospital and Advocate Trinity Hospital. I'm going to briefly introduce Dr. Mital real quick before Dr. Palla gets started. Dr. Deepak is the surgical director of Advocate Christ Medical Center's renal transplant program. He trained in England for a fellowship of the Royal College of Surgeons, LRCS, and Doyle in Glasgow. He completed the fellowship in multi-organ abdominal transplant surgery at Albert Einstein Medical Center and Temple University, and a liver transplant fellowship at Rush University Medical Center. Dr. Mital was one of the first physicians in Chicago to utilize steroid-free immunosuppression, and he has pioneered several breakthrough procedures, including sutureless kidney transplants, and micro-invasive living donor nephrectomies.
Yep.
So with that, thank you both so much for being here with us today. I'm going to turn it over to you, Dr. Palla.
Good afternoon, everyone. Thank you for the introduction. So, I'm an endocrinologist, so I do hormones, issues that most of what I see is diabetes of the time. Diabetes has insulin-based hormone that is involved in that inhibitors, and that's what we specialize in taking care of that cancer. So what is diabetes mellitus? It is a Greek for passing through of honey or sweetness or making of sweet uric acid. That means in olden days when we didn't have blood tests or anything to say what somebody had, if somebody had diabetes, what they had was the urine smell sweet or the mediated fatigues that the ants were around the urine of that person. So it was a sweet urine. And so passage of sweet through your body, that is your kidneys are exposed to the high sugars and your urine has high sugar. That's how the name came as diabetes mellitus. Mellitus is sweet or honey passage. So glucose is the main source of energy for all of both our brain, muscle, liver, kidney, all the cells use glucose as the main source of energy. So glucose is the substance that is in your blood. So that gives the body use for energy. Insulin is a hormone secreted by the pancreas, that's a gland behind your stomach that regulates the levels of glucose in the blood. And so, what is the source of glucose for our body? It comes mostly from food outside, all the starches, sugars, milk, actual sugars, sucrose, the different types of sugars and starches that we get from food like rice, wheat products, all the things. This all is converted to in our body as glucose and digested, and that goes into the bloodstream, and that is used up for ourselves as energy. In the fasting state, sometimes even if you're not eating, the sugar can be higher there because our liver has sugar stores as such, and our kidney and liver is able to make new sugar, also using some substance of protein and fat to supply an energy when we're in fasting state, when we're talking about a prolonged fasting state as such. So the insulin and the glucagon are the hormones that regulate the glucose in the blood. So the insulin acts as a key for the glucose channel that is on cells. These cells are mildly part of our body as such, and let the cell take up the glucose. That uses as a key. But there are other parts of the body which also play a role on how this glucose in the blood is used up as such. The muscle takes up insulin and the glucose, and which is dependent on insulin to that. The brain uses it. The liver has to take up the glucose, and the excess is stored as something called glycogen. So when it is needed, it is released back as glucose into the blood. The pancreas, then these two hormones, the insulin and the glucagon, eliminates the blood sugar passage. And the kidney also, so part of the outer part of the kidney called the cortex also contributes to making new sugar from fat and protein molecules in our body. There is no actual source of glucose coming from outside. And the gut, so the gut is there, all the food is digested, changes into glucose. It is part of it is reabsorbed as such, and part of it is let go so this is different ways, different parts of the body also regulate how the glucose is used up from the blood. So what do we say diabetes? This is a mathematician ask what is normal. So if you're waking up, you have not eaten for 8 hours or so, the fasting sugar of 100 or less, and you've got a little eaten some sort of sugar store, the food that you got, or IV as such, and the sugar should not be going more than 140. So that means there is no one single number. Even for a normal person, the sugar always fluctuates a little bit, but how high is the fluctuation? And when, so the blood sugar fasting, you're waking up already with the 150, blood sugar of more than 126, or blood sugar of more than 200 of the release, those blood sugar go to more than 200, or another A1C is another blood test that we use, which gives us an idea of average of your sugars in the last 3 months. So that number is more than 6.5 is diabetes. That's when we do the diagnosis of diabetes. So in between there is a pre-diabetes state. So blood sugars are not as high, but are not completely normal. That is probably a stage to progression towards diabetes. There's many other factors that contribute for you not to be able to maintain a normal sugar. So all of that comes to pre-diabetes. We use it as to screen patients, trying to prevent patients with pre-diabetes state. So that's how we use the criteria for that now. So there's again diabetes type 1 and type 2. Type 1 diabetes is when there is pancreas doesn't make insulin at all. That means there is no key to let the sugar into the cell. Most of the sugar like glucose stays in the blood itself. And type 2 is yes, they make insulin, but they have insulin resistance. That means the cells are not effectively able to take the sugar, and that causes the blood sugars to be high in the blood itself. There's medication that we use pills before we have to do insulin that can decrease insulin resistance. So they can still use their own insulin to bring the blood sugars down. So that's what we call type 2. So both either way, when the sugar is high in the blood, how does it affect your body? So again, there's a difference is the type 1 that usually diagnosed more younger. It's an autoimmune disease. That means the body made some antibodies against the pancreas, the specific cells that make insulin, damage them over time, and that's what leads to the type 1 that we don't make any more of their own insulin. Type 2 is many times hereditary, the weight, the environmental factors, many things that add to insulin resistance and genetic factors that cause type 2 and people are diagnosed usually for older. The type 2 is a lot more common than the type 1 as we see, which can put the value type 1, most of the other people are type 2. But what are the symptoms? So when your body is exposed to short-term of high sugar, so what happens? You're tired because the muscles of that brain and muscle is not able to use the blood sugar efficiently access to the source of energy. Your body has to use other sources like fat and muscle, so they're tired. Your kidney is trying to flush out the high sugar. So with the sugar, it takes water. So you are urinating, you are absolutely hydrated. So you are also very thirsty. So because your brain senses that you're not getting enough glucose, so you're always hungry, trying to actually give them more energy, but no, you can't do it. So the weight loss, because you're using your muscle as the main source of glucose, so your weight loss. Then other endorsement damage where the wounds, the cells, white blood cells that is glucose to heal wounds they're not working well. So those are the symptoms when blood sugars are acutely high and suddenly somebody developed diabetes just recently. Those are the symptoms that they feel that when they end up in the hospital or in the clinic, or sometimes just like that, just they found out even before any of these symptoms have occurred. But what we are more worried about is the long-term effect of diabetes as such, and that is the kidney disease comes. So all the sugar that's into the blood is hanging around, which cannot be flushed out anymore from the kidney. They're even taking medication, the wife, and we are trying to decrease the source of the sugar by eating better, as such cutting down the supply of the sugar, and still the sugars are high in the blood. So those sugars attach to some protein molecules on the blood vessels. So it is damage to the blood vessels of different organs that leads to the long-term complications. So the blood sugar along with the protein causes some products that deposit in different blood vessels. They're called advanced glycation end products called Ages, and that's what causes damage or inflammation. So inflammation is if we have a wound, we have swelling, redness, and leaking, fluid comes out as such. You can cover any wound anywhere.
Oh, okay.
So that inflammation can happen on the inner side lining of the blood vessels. If it is the big blood vessels of the heart and the aorta as such, that damage can lead to spaces in the arteries that can lead to cholesterol deposits and cause coronary artery blockages, which leads to stroke and heart attack as such. But when it happens to the small blood vessels, the kidney access, there is leakage of protein. So a kidney artery is always trying to produce, it works as a filter. So that kidney is our filtration system. That if it is damaged, it can filtrate more than what it should be, of the wrong substance than what it should be as such. And that's how the kidney is damaged. The blood vessels are damaged, or the small blood vessels that end up in the eyes are damaged by this deposit. And that's what is the retinopathy that we call, leading to leakage in the blood vessels in the retina, the back, the lining of the eye is called retinopathy. So we call this nephropathy, and the damage to the kidney and the damage to the eyes are called the retinopathy. As such. And other consequences, as I said, depending on the where the organ is damage to the vessels of the your circulation that can cause the gangrene or loss of circulation in the toe. And that's what ends up in foot ulcers leading to amputation and such. And this the blindness could be the letter and the result of damage to the eye. And we are going to talk more about the kidney damage, how that happens. So diabetes network, up to 40% of patients with diabetes type 1 or type 2, depending on how they control as they end up with the chronic kidney disease. And diabetes accounts for 44% of kidney failure. Since kidney failure has other reasons other than diabetes, but it is one of the leading causes of kidney failure, the diabetes fully controlled. So just to give an idea how we assess the damage to the kidney assets and what's happening. So it is the small blood vessels. This is the filtration system. So the kidney has many millions of the small filtration system called the glomerulus and the arteries that go. And so that this is where the filtration happens. This is where exchange of fluid and all the waste substances, protein, glucose, and all of that happens. Where the kidney tries to remove the excess of the waste and what's not needed as such, and tries to keep back the blood what is needed back. So if it is the diabetes, so those damage to the blood vessels, the small vessels can cause the issue, and that can cause protein. So protein should be absorbed back into the blood from the kidney, but some of it is being in the kidney. So that's the starting point of possible damage to the kidney as such. And you see that as further damage happens, there is loss of the circulation is lost, and some of the outer part of the kidney is also scarred because there doesn't get enough circulation because of the damage to the small vessels to the kidney. So this is what we call the protein urine. So protein in the urine we're eating, and that's what we assess with the blood test, urine test, or the urine albumin creatinine ratio. So you come into me, you're coming to your general doctor, they want to see how your diabetes is doing. So they use your blood sugar number to check your A1C. So they're also monitoring so to make sure there's no damage happening to your kidney, eyes, and the nerves. How do they assess the kidney damage? By using this urine test. Sometimes they do it in the clinic where they can do it with a deep stick, or sometimes they send it to the lab to check that actually the urine albumin, the urine and they use the calculation. The urine albumin creatinine ratio is 30 or less good, but if it is more 30, then it may indicate that the leakage started with the kidney and early sign of damage to the kidney as such. And when this progresses, and so the other test that we use is GFR, the glomerular filtration rate, how well that the kidney are filtering your waste and the fluids from the body. So that's called the GFR is another blood test that's measured on the blood test. So with age itself, your estimated GFR, that is how good your filtrate does come down. But with diabetes or further as that further damage happens to the kidney, we now with that giving the name of chronic kidney as such, and we have different stages. So the doctor may say, so it's still mild, the damage to the kidney is still mild, it's filtrated. So it's about functioning still 90 or higher for the filtration rate. And depending on the stage, how as the filtration capacity goes down and up, they give the stages of the kidney disease. Such. And this also may denote that the kidney is also going through more and more damage when this blood test is showing up as that you are having more and lesser GFR. It may also mean that the kidney also anatomically is going through more inflammation, more scarring, more damage, and loss of other functions that the kidney does for us. Yeah. So when do we send to a kidney specialist? So we are screening we're trying to make sure everything is doing well. So there's the kidney functioning in the first few stages. This could be because of age, because of high blood pressure. Something can have a little once you get taught to start off with. We are monitoring that one possibly once a year or once every 2 years to the blood test to check your GFR, and but once a year we usually check the protein in the urine. But when the protein in the urine goes higher or it doesn't match the disease, the blood test being counted, that means there is a lot more protein here than what the kidney disease shows on the blood test. It might be something else going on in the kidney. There's many autoimmune diseases that can affect the kidney and kidney function, and sometimes protein in the urine is a sign of those. So then we send you to the nephrologist to be looked into another source of kidney damage, to be a kidney biopsy as such. So when there is mismatch or there's lot of protein and all the kidney disease state indicates work as such, that means the other functions that the kidney does, not only the filtration was affected. That's when we send you to the nephrologist, the kidney specialist, who is more specialized in taking care of kidney. So what are the other functions of the kidney? It makes some other hormones and enzymes that can help you with the bone build up, it regulates how you use the calcium and phosphorus, which are the main substrates of bone, how your muscle uses potassium as such. So, and some hormones that regulate your blood pressure, how the blood vessels constrict and dilate and relax as such to the lungs and heart. It makes an important hormone called erythropoietin that is important for your blood vessel production, red blood vessel production as such, and how well it filtrates overall your toxins, your medications that you take involved from the toxins from the food. So all of these are affected as the kidney function gets worse. So what we can see is sometimes the potassium levels are high, low calcium can be there, high phosphorus can be there because of the toxins accumulated polyemia in the body. It can cause blood bleeding problems. It can irritate the heart lining and cause pericarditis as such, and active vessels coagulate to build up more toxin acid in the body. The fluid is not, so you are not able to filter out your salt and the water out of your from the valve, so there's the retaining of more fluid that puts the strain on the heart and can cause heart failure. So that's what happens as the kidney function gets worse. So in the early stages where there's some protein leaking, you really may not see any symptoms unless there is a lot of protein in the urine. And then you can have in the urine some foam in the urine that we cause, that could be one of the early symptoms. But as the toxins accumulate, you're not able to filtrate more water and fluid, that when you have the symptoms of muscle twitching, nausea, poor appetite, not able to sleep well, fatigue, severe fatigue, and the high potassium calcium levels in the blood can cause irregular heart rate and arrhythmia problems. And that's when possibly those are the symptoms of actually like advancing kidney disease, was the stage more than stage 3 or 4 and 5, where we call that this time almost coming near to end stage 4. So as we said, because of the other functions that so in patients with the chronic disease, diabetes or otherwise are also known to have more heart events, stroke, heart attack, and leading to death after. Also, even if they have or they do not have diabetes, they end up on end-stage renal disease, needing dialysis in the way where they have used the blood vessels or your abdominal wall to help to filtrate or go to kidney transplant. And it is known when we know that there are all these signs of the kidney being damaged with the protein, that means by that time with the eyes, the blood vessels are also possibly damaged. These patients are known to have diabetes eye complications also with the eye. So when we see the damage to one one organ from the diabetes. We stress the point is screen where we send them to go to the eye doctor more frequently, make sure they are in good shape and address their eye health also. And what we can do to prevent this. What puts you at risk of the chronic kidney disease aspect? So the diabetes, food control, high blood pressure is another big factor that is contributes to the kidney dysfunction. So similar factors that are causing the diabetes damage the blood vessels, the high blood pressure also damages the blood vessels for the kidney and causing constriction of the blood vessels and pimples. And other one, so overweight is a big stress on the kidney to cause other addictions like tobacco use, alcohol use. And with age itself, as we showed, sometimes a little bit of the kidney function does not done. So what can we do for this? So there's sugar control. So that's where my role comes in as an endocrinologist, and even before that, before the primary care physician as such, and then in your hands when you're checking for the sugar, you have diabetes, we want the sugars to be under control. When you wake up in the morning, fasting state, no more than 80 to 130, the sugar is not going more than 1 of eating. That comes to a A1C of 7% or less as such. And that's what, so there have been some long-term studies done in the populations, different populations of the world. And they arrived at this conclusion that at least if you are able to see this number of 7 or less on A1C, those patients, they saw that they really did progress into having this complication in the long term. We are talking about 5 years, 10 years of exposure to high blood sugars and end up having this complication. So these are not lucky symptoms. So we have that control in the long term, for long we want the A1C 7 or less. So we use medication, we can use the dietitian, lifestyle changes, all of those help to get the sugars under control. And blood pressure under control. So that also for studies is about 140 by 90 or even less than somebody has diabetes, but it adds to more weight. We wanted the sugar, blood pressure to be even lower at 130 by 80 as your goal for the blood pressure. So other, right, as I said, other exposures, the smoking that also damages the blood vessels, the arteries of the your different organs, cigarette smoking, alcohol use, and they're able to lose weight, maintain lose weight, and exercise, any type of exercise, like aerobic exercise or strength training with weight, anything is helpful, and not only for your blood sugar, but also to reduce your blood pressure, lose weight, and reduce the stress of the kidney. So sodium salt is again another big contributor which adds to the high blood pressure, how your kidney is able to flush out water and regulate the fluid levels in our body and the lungs as such. As you progress towards the kidney disease, you have to be more careful about how much more you can stress your kidney first, so that when you have to be more strict about salt, water, some of the other molecules like the potassium, phosphorus, and calcium. We have so that because at some point when your kidney can't filter out everything and metabolize all of them, so we have to see the exposure of these substances. You may have to meet a dietitian or read more about what can stress the kidney, what's not good, what the kidney cannot filter anymore, or do the best job in terms of increasing the amount of phosphorus in your food. There's something called calcium binders, phosphorus binders that the nephrologist might be prescribing, but also important for the The other thing is about heart healthy food. So when we talk about heart healthy food, it's foods that can decrease the inflammation of those blood vessels that leads to decrease in the accumulation of cholesterol deposits, leading to less blockages, less heart attack, less stroke. So that, as you saw, even the blood vessels of the kidney also can get blocked, the small blood vessels. So eating heart healthy foods, like avoiding the exposure to fat, using boiling acids, fried, reducing the saturated and trans fat, which also in turn protects the kidney also. What else as a physician do I do, or the nephrologist does? So in terms of the diet, if we're talking about kidney disease and such. So one thing is what the medication is doing to the kidney, but the other thing is also what the kidney is doing to the medication. So there are many diabetes medications that we give both pills and also insulin at the end, any type of insulin that we are talking about as such, which are metabolized by the kidney. So the kidney function slowly getting worse. That is based on the stage where we are. We cannot use some of the medication, so we have to reduce the doses of some of the medication. One of the biggest thing my patients ask is metformin. Metformin is the first line of medication, one of my favorite drugs. That is the first medication that is started for type 2 diabetes patients. It's quite effective that as the diabetes progresses, it can't do all of the job. So as diabetes progresses over time, depending on lifestyle, depending on your weight, we add more medications to metformin. So unless your kidney function is worse to the stage 4, I may not stop the metformin. I may just reduce the dose. So, like for 10 years ago, this was not the way. Once they saw some early kidney damage, they stopped the metformin. So the patients got the benefit of insulin resistance, decreasing the insulin resistance the metformin offered. So there was one good medication out of the list once they developed some early kidney disease. That studies have shown, and new recommendations are there that even at stage 3, depending on where your kidney function is, I may use the creatinine number or the GFR number, but I may reduce the metformin dose, but even at a lower dose, still offering the for your diabetes control. But at severe kidney disease, once the creatinine goes more to 2, or the kidney early stages, then I can stop the metformin. Some other medications like the sulfonylurea or even insulin hangs around in your body for a little longer time because the kidney is slowly metabolized and their effect is more. They can cause more low sugar. So then I have adjusted dose of those medications as such. Then nowadays there are some newer medications which are using for diabetes, but studies have shown they actually protect the kidney. So I would choose that as your the diabetes medication compared to something else. So I would choose. So there's an interaction between all diabetes medications and the kidney, and based on, so that's where our specializing comes in monitoring the kidney function and choosing the right medication, which doesn't further damage the kidney that can get the diabetes under control. So what is the usual most common medication that we use? You might have heard something called ACE inhibitor and called lisinopril, these are the common medications used, or the ARBs called losartan, valsartan. These are the common blood pressure medications used, but they may be the first choice when you have diabetes or have early signs that the protein is leaking, because they may help you by dilating the blood vessels. They may help to increase how much protein is being, and then increase the damage that is happening to the kidney. So take use of lisinopril and medications like the losartan or ARB has shown to delay the progression even towards that stage when the disease, delay the progression of the how much protein is in your blood. Very more recently, there is a new medication in the class of SGLT2 inhibitors. If we have heard of Farxiga, Jyothsna, or Librarian, and those medications in the early stages of your kidney disease, there is still the early protein in the disease there. You have not developed the chronic kidney disease yet. You are before just around the stage 3 kidney disease. Until then, those medications also by increasing how much oxygen your kidneys use to do all this filtration, of the sodium and the glucose side, increasing the oxygen stress, has also shown cause of kidney disease. So some nephrologists, even somebody doesn't have diabetes, are actually now choosing this medication, which initially started off as a diabetes medication to prevent the progression of what we call proteinuria, so decreasing the amount of protein lost in the urine and such, and decreasing the progression towards the chronic kidney disease and end stage of the kidney disease. So this is what we usually do: monitor your kidney function, look at the urine test and the blood test as such, counsel you on what you can do to prevent, catch it early before you end up in the end stage disease as such, and what are the medications, what we can do help you to increase the progression of the problem. That's where at the end, if when the end stage disease does happen. And so some of the other exposures, like having somebody has a kidney stone, somebody has contrast, they were going for a test and they're exposed to iodine contrast. So there's many other exposures that can also damage the kidney. So but when patients with diabetes, the kidneys already are delicate, already prone to much more damage as such. So we need to avoid or be more careful about other toxic exposures that taking NSAIDs, ibuprofen, painkillers, pain pills, which also cause further damage to the kidney. So we need to be very careful at which stage your kidney disease is. Be careful on avoiding all other exposure. Keep yourself hydrated, because dehydration is also one way when your kidneys are not. Then the blood, when you're dehydrated, the blood circulation to the kidney increases because the blood get back constricted or narrowed down, and that leads to further damage. Keeping yourself hydrated, and depending on which stage. If you're at the end stage of kidney disease and your body, your kidney can't filter out too much water, then you say you need to think less. But then the kidney function is still good, filtering out well. Until then, you are able to drink more water. That's all help the kidney flush out better and work better. So this is where I will ask the question, and then Dr. What will happen after somebody is actually going to demonstrating and how can they help you that.
What causes the blood sugar numbers to just keep going up? Like they do the fasting.
So as I said, in the very first slide, they said that your liver has glucose stores, and your liver and your kidney has enzymes that you can use your fat and other molecules to make new sugar. So when the insulin, which is to be there in the body throughout, in the fasting state or while you're eating, and the insulin hormone is less, your liver puts that, your kidneys put out new sugar. So even if you are not eating, even in the fasting state, sugar can be high because kidney and the liver are contributing.
So the fat test is that you're supposed to fast for 8 to 10 hours?
Usually, yes.
And is that pretty solid time that it really should stay within time?
So we use that fasting blood sugar, but that doesn't determine everything. We use that as only a screening test.
So when I was talking about it going up, so 8 hours, 10, 12, 14, 20 hours.
Yeah, so your liver and kidney have stores for at least 48 hours. So because it's a protective mechanism of the body for somebody who doesn't have diabetes and doesn't have a source of food, your body needs to still survive. So it has up to 42 hours of storage of glucose in different parts of the body that you can use them. Or it will use, if you're not giving any more sugar, it will also use up the muscle, the protein in the muscle and the fat to make up new sugar. That's how our body has protective mechanism to find other sources of sugar or other sources of fuel for us. And that's how those is converted to glucose. So Not always, that's why I did try to start off my slide by saying in the fasting state, your sugars are high because your body knows how to make sugar from its own heart.
So even if it's like in a good range, after 10 hours of fasting, you know, the overnight is in the reasonable range. And then with no food and into the night, the next day, without food. So now it's into the next night. And
So when you do have diabetes, that means your insulin hormone is not working well. That's what happens. So insulin also prevents too much sugar correction in the fasting state. So if your insulin diabetes type 1, you're not using, you don't take insulin. Somebody misses insulin for 1 or 2 days, you take from outside. Their body can't use sugar. It tries to use the fat and muscle to make the sugar. Such as the sugar can be very high because they don't have a insulin hormone. And glucagon is another hormone which comes in effect in the fasting state, trying to make more sugar. So while insulin tries to bring down the sugar, glucagon is not heard much, and we don't have it as a medication. There are new therapies coming up to work against glucagon. Nowadays, that will be the next advance possibly. But glucagon is another hormone that the body is always trying to make the sugar go high. So the body does make that. It has a protective mechanism. Just that it's not good for the diabetes patient. That we're trying to keep the sugars down, but that protective mechanism keeps the sugar high.
So should a person continue to fast as the numbers keep going up? Or should we actually have?
We take medication. So we take your next medication as such. That means you are doing as much as you can with your lifestyle, that means controlling the food and exercising, trying to use up the sugar as such, and the sugar is still high in the blood. That means there's not much you can do anymore about lifestyle. You have to use the medication, either take insulin as a hormone or take the pills that sensitize your insulin, your own insulin to work, and will help you down the sugar. So that means that sugar now will be used up, taken up by muscle, liver, when you use this medication or insulin will be down. So there's no one way that this sugar can. That's how people end up in the hospital. Anytime that there is a certain stage of diabetes where just fasting lifestyle will not work. They use medications to have to make your insulin.
Right, but if there were more medications before any of that happens, then is it better to have small bites to eat, or is it better to keep fasting so the numbers stop going up?
So I would not use fasting as a treatment for high sugar. At some point, there is a limit. That means your insulin, but that the fact that you said that they're not still on medications or they have early diabetes, that means whatever little insulin is there at some point will start working and will bring down the sugars. So that means lesser the sugars coming down, then the insulin is enough to bring it down further. So somebody is really going continuing, that means their diabetes is not well controlled. That means they have progressed to a point where they need medication.
And is there a general price range? If we had a list of 20 medications, what would be the price range of this medication?
That is another slide. That is another slide of the metformin, glutathione, actose, rapamycin, which are up
You just
to,
go.
like general insurance or
There
general
will be reports, but if you don't want them. Oh, yeah.
Insulin also comes in different range. At Walmart, you can get a certain insulin at $25, but other insulin can be up to $200.
Like in a month? Or?
Yes, these are monthly per month supply. Definitely, we come to a limitation where how much we can prescribe what we can cover. That is one of the biggest factors that prevents from the best control of that. I think Dr. Michael,
Thank you, Dr. Palla. That was a good talk. So, so now you heard everything about diabetes and kidney disease. And I hope anybody with diabetes who's well controlled should not come to kidney failure. But if that happens and they end up having kidney failure, then the answer is either dialysis or a transplant. So we'll talk about this. If somebody has end-stage renal disease, which is ESRD, they can either get dialysis through the blood or hemodialysis, or peritoneal dialysis through the stomach, or get a kidney transplant.
That's good.
So here's the most common ways end-stage kidney disease is treated. You can see the most common is hemodialysis. Less common is peritoneal dialysis, 5%, and 30% of people get a kidney transplant. So after 10 years, people who are alive, you see the majority of those that are transplant. 56% of people who are alive after 10 years of having kidney failure have a transplant. Hemodialysis is 32%, and peritoneal dialysis is 2%. So that shows you that if somebody has kidney failure, they're best off if they have a kidney transplant. Also, there's quality of life benefits. If somebody gets a transplant, they can keep working, maintain their employment. They can have a relatively unrestricted diet, freedom to travel, because if somebody's on dialysis, it's very difficult to travel. They have to arrange for dialysis in the new place. Ability to become pregnant and bear children. If somebody's on dialysis, it's very hard for them to have a baby. And a lot of them end up in abortion or preterm delivery. So it's not good if they're on dialysis. They can engage in sports, and their lifestyle is free of dialysis. It's free because a lot of people in hemodialysis have to go to the dialysis center 3 times a week, Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday, sit with the machine for 4 hours, and they take off fluid. So it's a big lifestyle change if you're on dialysis. So who's the kidney transplant recipient? Well, you can see the majority of them are those with diabetes. 31% of patients who get a kidney transplant have diabetes. Next up is hypertension, 26%. And the others are arthritis or polycystic kidney disease or neurological problems. But the majority is diabetes and hypertension as causes of kidney disease or transplantation. This is the life expectancy of patients who are on dialysis and transplant. You can see that at any age, dialysis in the dark blue, the lifetime years is not as good as they have a transplant. So you can see the main survival advantage is if somebody is say 0 to 14, with dialysis, they'll only live less than about 18 years. With a transplant, they'll live above 50 years. So at any age, it's better to get a transplant than be on dialysis in terms of survival. This is the survival of kidney transplants. You can see that if somebody has a living donor, their kidney will last the longest compared to a cadaver donor, somebody who's brain dead, had a roadside accident, or had a brain hemorrhage and the family decided to donate the organs. Those cadaver donor transplants, they don't last as long as a living donor. But it's still better than being on dialysis. So when do you do the transplant? Well, you can put them on the waiting list if the GFR is below 20. Dr. Palla mentioned about glomerular filtration rate or percentage of kidney function, roughly. When below 20, they can be placed on the kidney transplant waiting list. And when they need dialysis, instead of getting dialysis, they can get a transplant if they have a living donor. Right? Otherwise, the waiting list right now is about 5 to 6 years, depending on the blood type. So, the big question is, you ask the patient when they come to see us for transplant, do you have a living donor? And the answer is yes, it's very good for them. They don't have to wait for a deceased donor for 5 to 6 years. We also do immunological evaluations when people say, do you have a match? Right? What's a match? Well, it's a blood type. It's like an ABO blood typing, right? Blood type O can give to everybody. Blood type AB can take from everybody. Also, we do HLA typing. It's also called tissue typing. It's done with a blood test. We look for antibodies in the blood. And if somebody has antibodies, we don't do the transplant because those antibodies will destroy the kidney transplant. So all this is tested before the transplant to make sure it's safe and the kidney works a long time. So how does one form antibody? Well, if somebody had a blood transfusion or had a previous transplant that they rejected or has multiple children, then they have antibodies because you're exposed to somebody else's protein. Like somebody, you got a blood transfusion, somebody else, you make antibodies. Say you have a previous transplant from somebody else, you make antibodies, right? And as far as children, when the baby is born, there's some fetal maternal exchange of blood at the placenta. So they're exposed to the baby's blood, and that way they can get antibodies. So antibodies are not good when it comes to transplantation. How about the donor? Well, there's a living donor we talked about, and there's deceased donor, right? Somebody's brain dead. Living donors can be related or unrelated. So related means parent or siblings or children, right? Biological unrelated would be usually your spouse or your friend, right? Also, sometimes an altruistic donor. Somebody just walks in the door to our hospital, get done at Christ several times. Young person walks in saying, I want to donate a kidney. So we ask them, who do you want to give it? They say, anybody. The first thing you do is call the psychologist, this person of sound mental health. Because we don't want to hurt anybody, somebody who's not a sound mental health will show up and say, okay, donate blood, take my kidney, give my liver or something. So I want to make sure they have a history of donating blood and they're otherwise altruistic, and only then do we go ahead. And we've had great results with those kind of donors. They usually good in Americans. One of the kidney doctors, the nephrologist I know, donated a kidney to his patient. And this is not the first one. There's another female kidney doctor I used to work in Russia before I came to Christ, donated a kidney to her patient. So all these are altruistic donors. You just give with no expectation of return. So living related donors, if somebody is a sibling, right? You can share the HLA of your parents either completely or 25% or 50%. So 25% of them are identical, right? 50% are half of that, and 25% are zero. Other relatives can be at best one half of life or 50%. So here's our case. Who wanted to get a transplant, the siblings got tested. One brother was actually identical. The ABO cross match was all compatible. And after 2 years, he's doing great. Family is one. This is the ideal scenario. We get a living donor kidney transplant from a well-matched donor, and they do really well long term. So if somebody has a living donor but incompatible, right? Now what do you do, right? Well, they can either donate to the list and get a next available deceased donor kidney that's been worked on, or undergo a desensitization protocol to remove the antibodies, or the best is enroll in a paired kidney exchange protocol, right? They give a kidney to somebody else, and their donor gives the kidney to their recipient. That's the best way to do it. So here it is. It's very simple. You can see that there are two recipients, different blood types, and the donors are not compatible. So they just exchange the donors, right? So everybody gets a kidney, and we've done that at Christ with exchange from San Antonio, Texas. We've done it internally. We have two pairs, not compatible with each other, the donor recipient, we have swapped the kidneys. So two teams go in, both kidneys are removed, and then we swap the kidneys, and it works really well. So how about the waiting list? We heard about the waiting list. Well, when there's no living donor, we put them on the waiting list. But this can exceed 5 years for blood types O and P, because everybody is waiting to get in line, right? The dialysis and the insurance. This is administered by the United Network Organ Sharing, which is based in Richmond, Virginia, and they can be put on the wait list when the GFR is less than 20. And the transplant center will only list the patient after we evaluate, make sure they're fit for a transplant. They don't just put anybody on the list when they walk in the door, right? And then we notify them in writing when they're placed on the waiting list for a transplant. So deceased donors, well, this is you can either donate after brain death. I've signed my driver's license. I'm a registered donor. Family knows about it, so God forbid, if you did an accident, you signed yourself as a donor, then donate. or the family might say, if you want to donate after cardiac death. So what they do is, they will take you off life support, and as soon as the heart stops, you donate the organ. That's called donation after cardiac death. So it can be standard criteria or extended criteria donors. Extended criteria is anybody over 60 or all in the 50 to 59 age group with 2 out of these 3 criteria, high blood pressure, death by stroke, or slightly elevated cerebral failure. So these are different kinds of disease donors. So here's the projected life expectancy from the time of diagnosis of kidney disease. Yellow is the best, right? You see yellow at every age group is the best. What is yellow? It's a living donor kidney transplant. The blue is next best. It's a non-ECT. And the brown is extended criteria donor transplant. So if you see, I said extended criteria donor is in the bottom. The donor has a history of high blood pressure or death by stroke or slightly abnormal kidney function. Those are extended criteria. And they don't do so well, but you can see everything is much better than dialysis, which is in green. The worst outcome, even in the older age group 65 plus, is if people stay on dialysis. So transplant is better in the age group if they're eligible to get it. So in conclusion, transplant has the best outcome, right? Living donor, preemptive means before you start dialysis is the best scenario. You have a living donor, you get a waiting list. No, just get a transplant, right, from a living donor. And the donor work, I must say that is very different. Or say somebody comes in to donate, we are very, very exhaustive in evaluating that person as a living donor because we don't want to harm them, right? And so they get a lot of testing. So I have to emphasize the importance of primary prevention of kidney disease. Dr. Palla is our answer. Better management of diabetes. All right. So I'm going to show you a picture of our transplant program. It takes mobility. Right. You can see over here on the right side, and then we have other medical doctors, coordinators, psychologists, diabetes expert, dietitian, social worker, and so we all get together to help the patient get a transplant. So at Price, we are approved by the United Network Organ Sharing. CMS is Center for Medicare and Medicaid Services. We are certified by that. We take part in this kidney pair donation. We talked about exchanging kidneys with which is again the United Network Organ Sharing National Program. Also, now you may have heard Advocate has merged with Aurora Health in Wisconsin, right? So they also have a transplant program in Milwaukee. We partner with them. St. Francis down in Peoria, and also Methodist. We talked about San Antonio, Texas. Exchange kidneys, very dramatic. We took the kidney down in Chicago, here in Oklahoma, and in San Antonio, same time. They flew the kidney from San Antonio to Midway Airport. We took our kidney to Midway Airport and exchanged it. We got a San Antonio kidney. We put it in. Some of you in the news, you can Google it. This young woman donated for her mother, and the kidney went to San Antonio. We got a kidney from there, and everybody's doing well. So at this point, we'll stop. That's Price Hospital, just down the road. If you haven't been there, it's great. So I would again like to thank Dr. Palla because she did all the heavy lifting because the topic was diabetes and kidney disease. My job was to talk about what happens if, despite Dr. Palla and her associates, you get kidney disease, you can get a transplant. So I'll stop there for questions.
I'm silly, but I've often wondered if someone's reconciling, is there a lot of pain?
Oh, for a kidney donor, living donor? So that's a great one. Back in the day, when we took out people's kidneys, they would get a huge cut. We had to take out the rib. Now it's very simple. Laparoscopic, a little cut, 2 or 3 minor little incisions. They go home the next day. I've had 2 people go on the same day. Like take the kidney out, they're fine, they go home, they go. Now, everybody's recovery is different. I had a lumberjack who went to work in a week, went back to work in Southern Illinois, living by the river, called me up, and off. I'm like, yes, sir. They're going to go back to work. I'm going to do a lumberjack. He goes, yeah, I'm going to work. Okay, go back to work. And then I had a stewardess from United Airlines who came to see me. And she said, can I get 3 months off? I'm like, what's the matter? Oh, I'm fine. I just want to travel and work. I get to fly free. then I use this as an excuse, you know, so we tell most people take 2 or 3 weeks off, you know, so they can ease into it. Like there's one donor who donated, went home, right? So the next day my nurse calls to check her. Can't find her at home. Won't answer her cell phone, now you're really worried. Turns out she's out in the yard doing yard work.
Oh.
Didn't have a cell phone on her, and answered the home phone. I had a businessman who came in from the Philippines, who donated a kidney to his sister. He wanted to go back home the next day. I'm like, don't you have to fly 24 hours? He goes, yeah, I have work. It's my business. Stop. I said, please wait a week. You know, we're sitting in the airplane 24 hours, there's whatnot. So anyway, so it's not, to answer, the long answer to the question, how painful it is, it's varies. But it's not that big.
Thank you.
Yeah. Yes, sir.
So for diabetes, for getting, first line, you know, checking on that, I don't know the difference between a nephrologist and an endocrinologist.
So,
And then if it's an option, you go straight to one of those, or do you, I don't mean about insurance and all that, but it's best if you have the option to go to the specialist first.
so everybody should have a primary care doctor. Most of those doctors are the ones that first make the diagnosis of diabetes. And most of them can manage a simple case of diabetes, but I think a referral to an endocrinologist is always a great idea. So in that, Dr. Palla, for example, will say, okay, this is this patient, he's been treated by a primary care doctor, they have their own metformin, you know, and these are the different points that can be different. They're doing diet, exercise, medication. Can they use some of the new medication, right? That kind of stuff. So that's what Dr. Palla does. She may not have to see the patient long term. She may just say, okay, you're doing a great job, stay there. Or she may say, oh, you know what? This person may need insulin, and we do something to prevent that. They have kidney disease. So she had a big alphabetical soup of medication. And even I don't understand those, right? Because there are newer medications coming out every day, right? And she understands it. So she can administer those usually better than the primary care physician. But doesn't mean the primary care physician is useless. No, because they can manage the average case without. As for the kidney doctor, you only get referred if the kidneys are affected.
So
That's later.
so first is primary, then endocrinologist, then.
The last stop is me. When the kidneys fail, then they come and see me. I hope they never see me.
Dr. Palla, you're an endocrinologist?
Yeah, yeah. You have another question?
No, I'm very curious, that's what it takes.
I was wondering if, for the diabetic, if they continue to get to whatever point, I don't know, but how many different medications typically would they end up taking at one time? I know it would be different if they're just, depending on how far advanced they are, but what would be the range of one pill a day to having a whole box of, you know?
So I feel that there's too many diabetes patients because I see almost all diabetes patients. When somebody who's walking into a primary care physician, they may have many diabetes just on metformin 1 year, and only then they think that they have passed 1 or 2 pills. So most of my patients might be on 2 or more. And I think type 1 patients, I can only do insulin. And for them, there's only one medication, different types of insulin. There can be pills for twice a day patients. But when it comes to type 2, when I started fellowship, so that was 10 years ago, almost at first, there were only 3 or 4 options that we had. 2 pills, a new injection that came out, and then insulin. But now within these 8 years, every year, 2 or 3 different types of pills. In the same class, 2 or 3 different brands of pills are coming. As such, we have different prices, with different insurance preferences, and then so if somebody really doesn't want to go on insulin, I have at least 4 to 5 classes of pills or non-insulin medication that I can give them before I say yes, you need to go on.
So 4 or 5 pills a day.
So So
Yes,
four
four-
are different kinds of.
four types of things, yeah.
I'm just talking about the daily,
It can be made that there are some medications we do take up to be like metformin comes and that comes and that comes and that comes. So these are there is active, there are at least 5 different types of disease which are on different organs. They're using different cognitive approach.
yes.
So they interact by supporting each other. So that is I need all 5 of them together before I start. So that's how advanced it is. But it does end up having more cost and everything. So hopefully that the end goes end up there in the dialysis. Thing.
Her job is to prevent people from seeing me.
Do you know if, cancer, chemotherapy, but more so, radiation, abdominal radiation, is one of the side effects of that?
No, because
And-
unless you have kidney cancer, even for kidney cancer, nobody radiates kidney. Nowadays, radiation therapy has become very, very targeted. You heard of proton beam, you heard of, different kinds of biomarkers, different kinds of radiation. They don't radiate the kidney.
What about 15 or 20 years ago?
It depends. It depends, what the radiation for, where it was. The radiation that's right, I've not heard of.
Radiation as causing inflammation of kidney and leading to the transplant.
Well, of diabetes or kidney damage or anything related to what you're talking about.
Not sure, no. So if pancreas is damaged, that can cause you that. Something like pancreatitis because of any reason. Sometimes in the long term can happen.
Well, you all have really good questions. You have one more?
What if, on occasion, your blood level spikes? Is there any home remedy that will help bring it down right away? I knew someone that needs fixing.
Yes, so I advocate in some patients where they have exhausted even the pills and still don't want to go on insulin. I have advocated cinnamon, berberine is there, chromium is there, gymnasium is best of. So again, they all have to be make sure that they are not affecting your kidney, monitor your kidney function, liver function. Also, when you're taking those herbs, to make sure they are not causing other types of damage. But yes, you can take it. Otherwise, exercise, drinking some water and eating less the next meal many times brings down the sugar. Also, it's
Okay, thank you.
Thank you very much.
Thank you.
Thank you so much for all the tech support.
Thank you. I didn't